I believe we have the schedule for 10:30 to 11:30. Do you have any flexibility, Dr. Holman, do you know, on answering questions going longer, or is that 11:30 a pretty hard stop for you all?
I am good till noon.
Okay, all right. So we have a little flexibility, Laura. So I want to thank you all for setting in, and after last night and the announcement by the governor, I just think this is such a timely discussion to have. We have health professionals from CentraCare joining us to talk about what's real with our COVID-19 for our community and our state.
I had to go by phone for whatever reason to get in. Yeah.
Oh. Can you mute that, Laura? So we have Dr. Ken Holman, who will talk just for briefly as an introduction, and we're also welcoming Dr. George Morris and Dr. Joy Plowman, who has her PhD in nursing and has been on the front lines with the whole COVID response locally. We're excited to hear from you all. So I'm going to turn it over to CEO Ken Holman. Dr. Holman, thank you.
Good morning, everyone. I suspect that all of us, looking back 2 months, would never have predicted that we live in the world that we live today. So we're all part of the same community. So thank you for the opportunity to have a conversation about not only a healthcare crisis, a pandemic, but also something that is tearing at the fabric of our community and our society. We'll address both aspects. The co-presenters with me today are Dr. George Morris and Dr. Joy Plowman, as Teresa said. CentraCare, the third week of January, roughly set up what is called an incident command center. It is tightly coordinated with the governor's office and other incident command centers for the large health systems in the state. It is actually derived from a military model for managing complex crises. And so Joy and George will walk through much of what we have done as an organization in collaboration with the state. They will go first, and then I will finish with some overall observations and then open up to questions. So I will turn it over to Joy and George.
Thanks, Dr. Holman and Teresa and our chamber. I'll start off and then Joy will kind of finish up. And I believe you said Laura is operating the slides?
Yes, she is.
Okay, great. So I appreciate the opportunity to do slides also too, because then we can have other visuals besides me in my office. But thank you very much for everybody. This is probably an example of work and connect, a lot of that connection that we have to do even while we're distancing. So this is just a picture again. We'll cover a lot of details and go ahead. Thanks, Laura. Next one. Just a little graphic. Again, SARS-CoV-2 is the name of it. It's a coronavirus, which is a type of a virus. COVID-19 is kind of what we're using as the common term for this episode. SARS-CoV-2 is the technical name for the virus. You know, we could spell out the initials. The picture just shows a little bit, viruses are a unique kind of organism. They actually can't replicate or reproduce on their own. So they use these spike proteins, you know, to get into our cells, and then they have the nucleocapsid, the envelope, you know, the membrane is part of, again, its binding, but then the center squiggle, that's their RNA. And that's what they take over our cell, and then our cell reproduces that. And then that is kind of, you'd say, the damage that is done by the virus getting into our cells, duplicating, and then our body's immune response to that foreign invader. This truly is a parasite, just on the microscopic level. Next one, please. A little bit of, you know, statistics, or I often hear, you know, we talked, some of this was about the myths or the questions. Early on, there was a lot of discussion about, well, COVID-19, it's like the flu, it's like influenza. It was predicted at one point to have about 60,000 deaths. You know, the flu traditionally is calculated at between 25 and 69,000 deaths per year. So as well, it's about like that. However, when you really look at them, so far we're up to over 82,000 deaths now in the US. When we really, so we're already passing that calculated. When we really look at the confirmed cases of influenza, that's a different number. So that is, the calculated number is an estimate, so an algorithm by CDC for how many cases we believe are. When you actually do on the confirmed testing, that's where it's down more in that 3,000 to 15,000 range. And so that's the number that I would use to compare to COVID-19, because the COVID-19 deaths that are reported really have a good criteria for generally test results are there, so you really know it. So as we look at the mortality rates of it, COVID truly is at least 4, if not 20 times as deadly as influenza. The other one that you can see there that it already passed, and COVID-19, I believe in the first death in the US was in early March, though I know they're pushing some of that back based on some post-mortem reviews of who had it earlier. So it might even be longer than that. But in essence, in the past 3 to 4 months, we've had over 82,000 deaths. Annually, opioids kills 46, gun violence and traffic accidents. So you can see just in a small period of time, it's already deadlier than many of the things that we worry about and focus on as a nation. The bottom kind of graph gives you a little bit of a highlight of the contagiousness. So R0 or R0 shows how many people one ill person could infect. So flu, typically one person gets 1.3 sick. H1N1 and the pandemic, the previous pandemic, 1918, led to between 1.4 and 3.8, so up to like 4 to 3 people sick from one ill influenza person. So COVID-19 ranges in more in that 5 to 6 range. There is some newer research saying with all of our distancing and measures, it might be in the mid-2 range, but certainly even with that, you can see that it's more contagious than other pandemics and other serious things. I put up, rhinovirus, common cold, easily spread, measles, easily spread. The difference with those is that fatality rate. So case fatality rate is if you get it, how many people are likely to die? So percentages of mortality. And that is where even comparing COVID-19 with the 1918 global pandemic it has a higher fatality rate. We are seeing that number perhaps coming down a little bit as a calculation as we identify more asymptomatic cases, even with some of the conservative measures for assuming there's a 5 to 6 fold asymptomatic case versus each identified case, we still see that COVID-19 has a higher rate, estimated around 1%, which is much greater than traditional influenza fatality rate. The other thing that's a challenge for COVID-19 is the duration of the contagiousness. So how long it can spread. And so that gets into that 2 weeks duration, which is much longer than many of the other pandemics and easily spread diseases such as traditional influenza. Measles, you're actually pretty safe for that first week, and that gives people time to do containment. COVID-19, we haven't had that time to do the containment. And then it's hard to maintain that is a challenge that we're seeing. Go ahead for the next one, Laura. This is just a little picture. Again, this is how fast things are moving. This was probably, 3 days ago, I believe, 3 or 4 days ago when we were at 1,400, and now today we're up above 1,500 cases in Stearns County. Benton County has 102, Sherburne County has 126. So even just in our little 3 counties here, we're above 1,700. You can also see part of our other areas of CentraCare where we cover Candy, Ojai, Wright County, parts of Meeker, Todd. We're well over 2,000 of the patients that we serve. Minnesota is listed. We're now up to 638 deaths seen in Minnesota, and the U.S. case is also climbing. Next one. This is a little visual that we're using for internal tracking. One of our challenges has been how much information do we share internally and externally. As a state, the healthcare organizations out of the state have not been in the usual world of posting our numbers, publicly. we are letting MDH take the lead for being the source of information. So even this information, I would appreciate people keep a little confidential, because this is our internal data, but we do want to share it. You guys are valuable members of our community, but this is truly for our internal use. We use the MDH as that public-facing side. Stearns County has some good information too, but this is just what we're using to kind of track how busy we are and how many patients that are COVID identified that we have in our facilities. And we have even taken some additional steps to it to track the ones in critical care. That's another factor that helps us look at and tell the story of how busy we are. Now, we also show our testing. Another measure and a big push for our governor, and Dr. Holman and the rest of the state is we need to do more tests. So we are really trying to do our part on that, and we've really ramped that up over the past week or two. So we have a way to track how many tests we're doing and how many tests are positive to kind of look at that positive rate. We also know that when we report CentraCare, that's not just our St. Cloud Hospital or St. Cloud area lab. We do testing for many other healthcare organizations and institutions across the region. So a lot of our numbers for CentraCare are truly a region-wide approach for the data. I'll go ahead to the next one, Laura. We also are trying to be very transparent and open about PPE, our safety supplies, our personal protective equipment. This is a case where everybody wants to know, how are we paying attention to safety? These are things that are even issues at the national level, and I think there are a lot of stories. So you say, how do we handle the myths? The stories being told of, well, we don't have the supplies we need. And I understand that, and I can feel that in our institution. What we have done with a great deal of effort, Joy and others in our procurement side and logistics, of making sure we have adequate stock, adequate supplies to last both now and moving forward for this pandemic. So we track that and we display it. And now our staff can really tell. Even this data is likely a week old, and the numbers change on a daily basis as our logistics team gets us more of our safety stuff that we need. Go ahead. This is just a little quick graph also too, so you can see that rate of change. We knew we were kind of going along slowly, in Stearns and Kandiyohi County. We saw a little bit of a blip, earlier in April. You can see maybe a little slight jump on that one. And then we really ramped up our testing. And with that, you can see both our cases went up, we identified some outbreaks, and we tested them intentionally, and I feel very appropriately. We wanted to find people because we wanted to give them the information they needed to care for themselves and hopefully manage and decrease the spread. And we wanted our own information so we knew what we were managing and knew what we were kind of seeing to help resource ourselves. Okay, next one. This is our way to track on a daily basis. So this is a way, and so our data on Stearns County and Kandiyohi County, two of our major areas, are in the blue. And with this, we can tell, well, what's our activity on a daily level? And it goes up and down. What we want to see is that it kind of starts to go down and stays down for a longer period of time. We know it's not going to get to zero. I think we're past that point that our daily cases are going to be zero. However, if we can see where it stays low, then that again shows that we're managing the spread, which is really what we want to do long term. The more orangish data is Minnesota. So you can see even Minnesota has a little bit of an up and down for the numbers of new cases identified. Go ahead, next one. This was a part of our testing strategy, and as you can see, a large spike here. This is when our Caris group, Wilmer, did a large outreach to their local poultry plant. And we tested over 1,100 people in one day. And that was just a tremendous work and example where we targeted our testing to where we needed it. And we really wanted to do that to identify our cases. Otherwise, we track them. I'd say internally, we have a goal to be around 500 tests a day at this point. That's about what we have, and we had to get that as a special request, and much appreciation to our team and Dr. Holman for letting us do that. Go ahead, next one. A little data. This is the other myths are I think about, well, we're doing our work differently. So this is our way to track how we're doing our work differently. specifically for virtual visits and telephone visits. So we just kind of use this as a way to see how many of our clinicians, how many of our clinics are shifting into, you'll call it that future world or the virtual world, the virtual care. And we're even able to track the financial outcomes of that. So this is a good way for us to keep, you might say, keep an eye and plan for a new future for perhaps many of these visits stick and that virtual care does become part of our future. This was not a large part of our care model, of our portfolio in the past, and our team quickly ramped it up and they continue to do it even now. Next one. This is maybe, I'd say we're looking at why are our numbers going up and why are we being concerned about safer opening in the future. And as the governor said yesterday, Teresa, you called that out, the new model, the new words might be stay safe, Minnesota. Not so much the stay home, but stay safe. With that comes this social distancing concept. So this is a traffic patterns. And we can see as we were doing well, our numbers were down very low. Easter came. And there were a few more things that people began to feel a little bit more comfortable and began to get out and travel a little bit more. Some of the stores got a little busier and we could see that traffic became closer and closer to previous ones. And we're seeing that in the part of the spread that we're doing. It's hard to have a cause and effect, but certainly they're going up together. So I want to be careful about how we reopen, how we stay safer as we're learning to live with this. Next one. And Joy, I have to try and remember when it's my turn, but I'll tell you a little bit. This one is, we also know that I would say people might ask the questions about, well, what are you doing here in CentraCare and St. Clair Hospital? So we have started remdesivir, and this is the new antiviral that many people have heard about or read about. And we have the ability and have now actually used that in our facility. So just a nice opportunity that we are staying on, we'll call it the cutting edge or leading edge for it. We've activated our surge plan. We're putting people in new areas because we know that the vaccine is still 12 to 18 months away. And there's still even consideration about how effective that vaccine is going to be and how long it lasts. We'll have to keep track of that in the future. Our teams are keeping track of the new symptoms that are being associated with COVID-19, and new clinical practice guidelines are being identified and implemented here, almost on a daily basis. Our teams are really trying to stay on top of what we should be doing as a tertiary care facility in our region. We're also making sure that we use the valid source of information. And I know there's a lot of discussion. I get sent comments or concerns. Our goal is to be a source of truth, a source of trusted information in our region. We do look at what is being shared and spread, and we want to make sure that we give a good voice. Next one. And I probably covered a couple of these too. These are some of the other steps that we've done. I think a couple highlights would probably be the universal masking. This is a way to protect both our patients and our employees. Everybody that comes into a facility is offered a mask. We've expanded our antigen and also now more antibody testing to look for who it could have protection against it. Our visitor screen is really hard and a challenge, and we have very strict limits on that. We're trying to be a voice in the community for encouraging face coverings, and I know I appreciate other members of the chamber and other leaders in our communities to kind of help keep our connection to that and really look at it. We've made significant commitments on our financial side, both for supply chain and support of our human resources, our people. Go ahead, next one. And this is just probably a little bit of a visual. Certainly, please do not read it. Just an example of that incident command structure, as Dr. Holman had said. It is highly coordinated. We have it almost seems like multiple times a day communications going on throughout our whole system. Joy and I sit as the leaders of the system-wide one. We have parallel structures that report into ours within CARIS and within the regionals, and that allows us to have local work groups. We are connected with public health and local businesses, even using forums like this, which I think is going to be a key part of moving forward. Okay, Joy, I think you got it now.
Great job, George. Thank you. So as Dr. Morris said, with the incident command structure, as the co-lead incident commanders, Dr. Morris and I help the team to set objectives each and every single day to continue to mitigate the risks and to be very thoughtful and planful as far as what we need to do, not only across CentraCare Health, but really across the region to prepare and be able to respond to what we're facing with the COVID response. The incident command really centers around our objectives and our purpose statements of to listen and serve, to guide and heal. But we've also created these guiding principles for our COVID work. And that really is to make sure at any point in time that we keep the care and the safety of our patients, our residents, our consumers in mind, along with our employees and providers, and on a broader scale, our community. Next slide, Laura. So we have developed very robust plans on how to mitigate these risks because we know that we would see an increase in volume, both from an outpatient setting and on the inpatient or hospital side, as well as possibly needing to care for individuals in our skilled nursing facilities. And we wanted to be prepared for that. So on top of the volume that we already see, we needed to plan very differently for this response. And so we created an acute respiratory clinic where we manage all of our outpatients in a setting that is attached to the hospital here at the River Campus Clinic in St. Cloud, of those that have a respiratory disease or illness, so that we can congregate those patients in one setting and to keep others in a more clean or healthy environment. We also implemented curbside testing. You've probably seen a lot of this in the media, but we not only implemented that in St. Cloud, but at all of our regional sites. And since initiating that, we have increased the opportunity to test people in the St. Cloud market and have expanded that curbside testing 4 times to be able to meet the demand of what is happening and changing within our community. In our emergency department, both here and at Rice Memorial, we have created a split flow entry so that individuals are quickly seen and assessed when they come into the building as to whether or not they may have a respiratory illness or condition or another ailment, because we still have to manage broken bones and other conditions in addition to our COVID response. So when individuals arrive, they are quickly sorted, if you will, and sent to a respiratory area or another area within our emergency department, again, to create efficiencies and to provide the best care to those patients. All of our regional sites, so Melrose, Sauk Center, Monticello, all of them are prepared to care for patients with respiratory illnesses and who may be undergoing COVID testing. And when patients become positive, if it's clinically appropriate or during the testing phase, if they deteriorate and they need additional level of service, we want to be able to congregate and move those patients to either St. Cloud or our Karis Rice location. This allows us to manage patients in a very efficient way, making sure that we are using the latest evidence and supplies as well as medications to be able to treat and manage their COVID disease. St. Benedict's Senior Community will also have the ability and has the ability today to care for individuals who are positive with COVID illness. Next slide. In particular at St. Cloud Hospital, and again, the same exists at Rice, but I'll focus on St. Cloud for the purposes of this call. We have designated distinct units that only care for positive COVID patients, so that we have a critical care or intensive care unit environment, and then a second floor which manages a more medical level of care for individuals who are positive for COVID. This again has allowed us to train our nurses, our respiratory therapists to use our CRNAs or even physical therapists in a very different manner to be able to target interventions for the best care of our COVID population. We have also taken staff who may not have been normally trained in our critical care environments. Maybe I'm a registered nurse and I normally work on a medical unit, And if I have an interest or want to be trained to a critical care environment to act as a nurse extender in that environment, we have trained and provided orientation for individuals who want to cross-train to be able to help out wherever they can whenever that need arises. We've redeployed some of our teams and our staff members who don't have as much going on in their work environments because of how we've changed things and implemented new ideas and concepts and innovations in order to be able to best manage the patients. An example is the creation of a turn team, because these patients, especially in our critical care environment, are very sick, and one of the strategies is to turn them often and in a position where they're lying on their stomach and possibly needing a ventilator that allows for better air exchange. And it takes quite a bit of person's power to be able to turn patients safely without dislodging their endotracheal tube and making sure that they're in a comfortable position. And so we have physical therapists and others that are now on this turn team in order to better care for patients, and especially who need quite a bit of person power in order to maneuver them. We are looking and ensuring that we have long-term staffing plans as both our needs increase and as we anticipate staff may become ill or simply need a break from this environment. And we are working very strategically with many of our regional facilities to provide care for the entire community and the region. Next slide. So in talking about the care of the community as a guiding principle, we have done several educational events and increased our media presence and tried to answer as many questions and concerns we have heard from our community members. And we want to be there for you in the event that you have questions or want to know information. We have targeted specific education to our populations of Somali, Amish, Hispanic, and the homeless, because we do know that they are more vulnerable and certainly more at risk. We've provided education to areas in our skilled nursing facilities to make sure that they know how to manage a little bit of a higher level of population. We've shared information with our schools, especially when it comes to what does it look like to distance learn and to yet be out and social, because this is a significant impact to our young adults who've had their lives changed, or seniors in our community who expected to have key events such as prom and graduation. So we are partnering with them not only on education, but also the psychological support that we feel or they feel is needed. And we are certainly role models for wearing face coverings in public and social distancing. That is something that our employees are very committed to, and answering questions about why that is so important. Next slide. When it comes to our regional surge plan, we do have a daily call with all of our regional partners, so individuals within and outside CentraCare, because as an entire central Minnesota region, we need to be prepared for an increase in patients with the COVID response in addition to what we normally care for. And so we want to be able to utilize hospital beds or skilled nursing facility beds when and where we have them available, and certainly to be able to share resources if it's needed. So we have a very strategic response that is leveled into Tier 1, Tier 2, Tier 3, and Tier 4. And again, this really comes to what Dr. Holman had indicated at the beginning of the call, in that we are very collaborative in working with the state to make sure that we as a region are completely prepared to care for what's ahead. Next slide. So support for our employees and providers. Again, if you follow the news or social media, you have seen the toll physically and emotionally that a response to caring for COVID patients may take on our own employees. There are ethical and moral dilemmas. It is physically hard to wear an N95 respirator or a face shield all day. And so we have provided a number of support mechanisms for our staff. First and foremost is the visibility and communication channels that we have created on a daily, and that really includes a 24-hour mechanism amongst our staff who are working here on weekends and holidays and every single shift. We have very robust opportunities for our staff and providers to give input into decisions. We have spiritual care available to make individual rounds or to pray with staff or to be up on visits not only for our staff, but for our patients as well. We have a peer support program where if a colleague maybe just needs to talk about something, they have the opportunity to do that. We've created streamlined opportunities to our behavioral health services if individuals feel that they need that, whether it's within CentraCare or our external mechanisms. We have several wellness activities and reminders to stay hydrated, to think about your emotional well-being. And every single shift, our patient care teams huddle together to kind of set the plan for the day and to check in on each other to make sure that things are going okay. Next slide. Things that you can do to continue to help us is to try to stay as healthy as you can. And that really means making sure that you wash your hands a lot more than what you ever thought of before. To continue to contain your secretions, so when you sneeze or cough, to cover that with your elbow. Avoid touching your eyes, your nose, your face. It's really easy and common practice for us to do that, but try as best as you can to be more thoughtful about that, especially during this allergy season. Avoid contact with people that are ill. Clean surfaces more than what we normally would, and to do that often. Stay home when you can, and to remember to practice social distancing, especially as we continue to open things up across the state of Minnesota, and certainly consider wearing a face cover in public. And with that, Dr. Holman, I'll toss it over to you.
Thank you, Joy and George. And again, thanks to the folks participating in the conference. I'm going to go at a very high level and talk really about several things. And before I talk about living with the virus, I'd mentioned 3 topic points that I did not want to put on a slide. First of all, reiterate why the COVID-19 pandemic is such a big deal. Sometimes in our day-to-day work, when we see the impacts to our daily life, we miss what's really going on from a big picture. Some historical writers have talked about the fog of war. I'm going to mention why COVID-19 is a big deal. Number 1, it is new. We have not experienced it as a Homo sapiens species. There is no immunity. There is no vaccine. And with the exception of remdesivir, there is no treatment. Number 2, this is a highly infectious bug. If I were to ask you how much money you would have if I gave you a dollar bill on June 1st, how much money would you have on June 31st? If I doubled it every day, it would be over $1 billion. So when you look at doubling rates, that shows you why we're worried about how infectious this organism is. The doubling rate is quite high. Third, the morbidity, how sick you get, and our patients in the hospital, they are sick. If you are on the ICU in a ventilator with COVID-19, you are a very sick human being, far sicker than patients who have heart surgery, cancer. And so the morbidity or mortality rate on this virus is remarkable. Fourth, there are targeted populations that are particularly susceptible to this virus. We know what they are. It's the aging and those with coexisting disease. But also this virus is spread by close social contact. And as you know, as human beings, we are social beings. And so this notion of not being social is difficult to our way of life, and really it threatens everything about the way that we live our lives. Fifth, we have been behind the 8 ball on this virus. We weren't as prepared as we could have been, but likewise it impacted the psychology of America. Most issues related to public health happen elsewhere, Africa, India. If there's a bridge that goes out, or a wildfire, or some other public disaster, it's over there. Now, Minnesota has had its share, but we have never had a pandemic that truly is global, and it impacts everybody. So as we look at why COVID-19 is a big deal, I wanted to refresh our minds from a high level of why this is really important. The response has been in Minnesota coordinated, thoughtful, apolitical, mindful of many stakeholders' opinions and the massive impact that it has on our public. The impact of CentraCare is profound. It is profound to your businesses. CentraCare's projected losses are somewhere close to $250 million. Our response to that follows the same themes that you are working on. Our cost and our losses on this can be put into a couple of bins. Loss of business. How do we build our protective equipment and our workforce to understand the dynamic needs of COVID-19 patients and preparedness? And how do we support our folks and prepare to help our communities? But our response is similar to yours, spending a lot of time on how do we rebuild, managing our costs differently, working with our workforce, including pay cuts and decreases in other benefits. And how do we understand the new normal? Because the new normal will not be the old normal. We've had to borrow money, apply for grants, but we remain committed to being here for the next 150 years. And so being here for the next 150 years leads me to the following closing slides, living with the virus. I think all of us need to understand that we will live with this virus for some time to come, until there is this notion of herd immunity, a vaccine, if you want to use that terminology. And so understanding testing and treatment and vaccination is really important. But as we reopen, there are two aspects to this that we need to understand. One is, as we reopen, what do your customers, what does your neighbor, what do you think about being close to someone else physically? Whether it's a baseball game, church, in your place of business. What efforts do we need to undertake to have people feel safe? That's not a political conversation. That's a personal conversation that each human being is going to have with their family. What does it take to make you feel safe? And the second thing is we have to be able to manage episodic hotspots. Is our health system prepared to manage rolling surges? Because this virus will crop up again. Because as we get closer together, it increases the likelihood of more hotspots. So as we think about living with the virus, think about what you, your customers, your family, how are you going to adapt to a social environment that's different than it was 2 months ago? And how do we make sure that we have the resources in our community, including our health system, to manage those patients that get ill with the coronavirus? Next slide. I think there might be one more slide. So this is the close. Follow the guidelines. When possible, stay home. Stay safe. If you're in the public, take appropriate measures and be well. And with that, we're open for questions, Teresa. And I might act as the moderator and probably hand most of them off to George and Joy.
Great, and Laura's going to ask those. I just wanted to alert people that we do have a number of other medical organizations on the call, and that many of them have gone to universal masking and telehealth visits as well. So it's important. I think one of the slides that shocked me the most in that was how when transportation and travel increased, how much increase we saw in incidents. That was pretty shocking. So I'm going to turn it over to Laura with some questions. Laura?
All right, so one of the questions in the chat is, what are emerging symptoms?
I'll try and take that one. Many of the emerging symptoms include the common ones had been fever, cough, shortness of breath. Cough and shortness of breath really being the key. And we've shifted probably into more of a, if you have one of those, or if you have more than one of others. And that includes a fever, muscle aches, shaking chills, myalgias, sore throat, loss of sense of smell or taste. And another characteristic of all these symptoms are that they are new or changing. A challenge here is it's also hay fever time, allergy season, and other people have chronic shortness of breath from asthma or COPD. So we really try to get at what's changed. And I think that's the key.
Okay. Another question, and I'll ask this one simply because you might have just answered it, but I want to make sure. Can you speak to what the average person with no underlying conditions in good health can expect from this disease? In news reports, it says that the vast majority of people are going to have mild symptoms. Can you speak to that a bit more?
Yes, Joy, you can get that one.
Sure. I think Dr. Morris just, articulated what most people experience, and some people are completely asymptomatic, meaning they're not really showing any symptoms, or maybe they're so mild that it feels like allergies, but it may be COVID. What I would also say is that even when people are done shedding the virus, which is, typically 14 or so days after the symptoms first appear, is that they may not feel well for a couple weeks, 2 to 3 weeks afterwards. They may still feel very tired, a little bit more short of breath than normal. So that is typical of an influenza-like illness as well, is that the recovery period for some people is a bit beyond when they're actually contagious.
Clearly, we know that there are vulnerable populations, and the two that I would call out would be our aging citizens, particularly in congregate living settings, as well as those with coexisting heart and lung disease and immunocompromised. That said, one of the things that's been surprising, at least wise to me, is that there are young people that are getting really sick and dying. We've had a newborn with coronavirus that was discharged, thankfully, but across America, we are seeing not only the vulnerable populations get hit, but there are the occasional youngster, 25, 30, 35, 40. And there were 3 infants, or I should say 3 children that died in New York. So while we know vulnerable populations, and no one is immune.
Okay. A couple of questions regarding antibodies and just exposure. So does exposure and the diagnosis of COVID-19 provide any antibodies or immunities from future exposure? And is there a way to test for that, or is it being done?
George?
Thanks. We do have antibody testing available here within CentraCare, and we are using it. We are identifying people that have antibodies. And the complex answer of does this help you in the future is being developed. I will also try to recognize when I don't know exactly what the answer is. I would say as a system, what we're leaning to our experts is saying it does look like antibodies that are developed help you out at least for the short term. Now, could short term be 6 weeks, 6 months, or 6 years? I think that's kind of where I think the current belief is that it's probably more in that 6 month kind of range. And that's a challenge because, as Dr. Holman said, we're going to be living with this for a long period of time. Sometimes antibodies do have a memory. In other words, if you get, say they last for 6 months, maybe 12 months from now, an exposure will trigger a memory, so it could wake back up at that point. But I think it's too early to tell. And that is one of the reasons why we are using it. We are just not using it on everybody because we're trying to identify what to do with the information.
Okay.
George mentioned that I'd like to use an analogy with the flu virus. So one of the questions about the COVID virus is what's the long-term view of this virus? Is it a one and done thing? Or is it going to be an annual cyclical process, much like the flu virus, where the flu virus mutates, that capsid coat mutates. And so as a result, every year, we do some work in a vaccine for that variant, for the flu, for that year, as many people as possible get vaccinated. And so as a result, in America, we end up with some kind of a definition of herd immunity, which is probably 40 to 50% of the population who either get a vaccine or have mild symptoms of the flu. So that's an unknown question yet about coronavirus. This is this notion of annual change, herd immunity, and what vaccination does long term.
Um, each of you mentioned testing with limitations to access and possible false negative tests. What expectation is there to CentraCare and its role in testing the community?
George, maybe start, or Joy, and then I'll finish with an end comment.
I'll start, Joy, and then you can finish up if as I miss things, because I generally do. So that's why we work very well together. Our role in testing in our community is big. I mean, this is what we are doing here. We have done over 10,000 tests. We've identified over 2,400 people in our communities for this. We do know that there is a false negative rate. Every test has, good and bad, and we are using the top end. In other words, there are some tests that I remember being sent advertisements for, and they were not even as good as a flip of a coin. In other words, guess whether it was not. But the tests that we are using are as good as I believe that is available. We are working with MDH and Mayo and the University of Minnesota and others across the state on that broad testing strategy. So our goal is to test people with symptoms and then do additional, I'll call it targeted testing in either at-risk populations, Joy spelled out a few of them, risk locations, whether that's an employer or a neighborhood or a geography, and really do the best job we can to give us as much information about what's the virus doing in our communities.
I'll just provide more of a operational experience. Is that it's been a really proud moment for me as a CentraCare employee, to see that a parking lot is empty and the next day it's filled with cones and a tent and a process to be able to test 750 people. It is just amazing, the teamwork and the collaboration that comes together in order to be able to serve our community in that capacity, and then to be able to take it down and move it somewhere else the next week. It is just absolutely amazing.
I would finish with 3 comments on testing for you to think about at a high level. A test is a point in time, and that's all. It just says on Tuesday when you had that test, that the result of the test is whatever it is. So how do we understand that point in time in the context of a week, a month, an epidemic? Some unknown questions there. The second thing about testing is the objective of the testing. The primary objective of testing to date has been to manage and diagnose and take care of sick patients. It has not been, from a public health perspective, to identify those who are at risk or are herd immunity or to reopen America. So the second point is, what is the objective of testing? What's the desired endpoint? And the third point is that there are significant shortages of everything in healthcare. George and Joy have done a marvelous job with our teams to have stuff on hand, but there is, because of the international impact of the pandemic, there are shortages of everything involved in testing, whether it's the collecting materials, the swabs, to the machines, to the reagents that do the test. And so how do we understand that in terms of global demand? How do we manage a significant supply and demand mismatch as we ramp up testing from just testing those who are sick or symptomatic to a broader healthcare perspective? So for example, if you do 30,000 tests a day, which is quite a few, and let's say you want to test half the population of Minnesota, which is 2.5 million people, how long will that take you to do? It goes to show you the dynamics and the challenges of doing this at scale. The population of America is roughly 350 million. Let's assume we've done 1 million tests to date. We've done 1 million tests in 2.5 months. We'll be done testing half the population in several years. And so I'm not being pessimistic or optimistic. I'm just saying this indicates the magnitude of the challenge at a population basis.
Okay, thank you. So lots of questions around testing, so I'm trying to combine them a little bit here. Somebody is wondering how does one get the antibody test?
Joy or George?
We have a process where it should be, I'd like to say, as straightforward as calling our contact center. That's 320-200-3200. With that, our nursing staff and advanced practice providers kind of go through a questionnaire, basically a online or a telephone evaluation of when did you have your symptoms, what were they, what's the likelihood that what you were experiencing was COVID. And with that in mind, then they can tee up or establish a test for you to get done. Now, the antibody test is a blood test. So you'll have to go to one of the labs for that one. And generally that request or that order is sent to your primary care provider. We also understand that our lab serves more than just the CentraCare docs and advanced practice providers and team, so that we do have a process for connecting with, I'll say use Health Partners as an example, an outside team. But I would just start by calling that number, and we should be able to get you your help.
Okay. Staying on the testing theme here, someone's wondering how CentraCare is handling or what they're doing to test pre-operative patients in the community.
So George, I'll start and you fill in the gaps this time. So as we work towards increasing the number of surgical and other procedures that require and have been put on hold over the past several weeks, we will be offering and have algorithms to open up pre-operative COVID testing. We want to ensure always the safety of our patients who are undergoing those procedures and also our staff. So a few days in advance of that procedure, we do ask that patients go for testing and have processes in place to do that. We also will be implementing that for C-sections and inductions as well, to make sure that our women who are having babies are also included with that. George, what else would you say?
I like how you laid that out, and I view it as it's a pre-op screening test. I hesitate to use the word asymptomatic testing. I believe that's, as Dr. Holman was talking about testing, that's more of a population-based strategy. Go test entire large communities or large numbers of people to find out what's out there. We are truly using this as a way to screen patients to make sure we are doing a safe procedure for them. If you have COVID and you have to undergo a general anesthesia or a high-risk procedure, it's riskier. This way we have the information and we can counsel the patients and the procedure lists, the procedure team, when to do it and how to do it and potentially where to do it. So it really is a part of our safe strategy. As Joy laid out some of those key principles we have, our safety for our patients, safety for our team members, and safety for our community.
What is your opinion of the latest Minnesota DHS model indicating a more than doubling of fatalities in the next 15 days?
George, I'm going to weigh in just to start, and George is a content expert. Models are not necessarily a predictor of reality. The models that we have related to viral disease management have a number of really important inputs. And George indirectly covered them: R0, infectivity, all that stuff. As you get more models that zero in, you get better. For example, there are two large weather predictive models in the world. One is run by the Europeans and the other is run by the Americans. And they are getting closer together as they take multiple inputs. But the modeling around viruses is complex. That said, they are directionally correct. And sometimes we want to argue about the size of the head of a pin. The difference for me between 80,000 deaths and 100,000 deaths is there a difference? Yes, 80,000 people still die. And so it depends on your perspective of how we manage disease and we want to reopen. George, talk a bit more about modeling.
I appreciate how you describe that. Modeling, we use it, and I believe that the role of it is to almost, you'd say, estimate if we do certain activities, safe activities, pull certain levers on the safety, the stay at home, the stay safe, the open up businesses. That will shift when our peak happens and how high the peak hits. You know, this concept of flattening the curve is a little bit of timing and a little bit of how high it gets. And I think, I apologize, I haven't seen that specific in the model. What I do know is that both we use our own internal modeling, our own internal data. We work with other large systems across the state, 8 or 9 of them. And we also pay attention to what MDH is doing, and even nationally, what the predictions are for us. We will see if there is likely unrestrained mixing of people. You know, in other words, if when we open our state, if we open at 100 miles an hour, think of that social distancing graph I showed, where if the traffic patterns and if our exposures really ramp up in the next 2 weeks, we will have more cases and more deaths. Our goal is to do that in a manageable way. And I apologize if that's a long answer, but that's how we're using models. And that's why our interventions have been steered towards both delaying it so we can respond better. If our peak would have hit a month ago, we would not have had remdesivir. We would not have had, you know, all of our staffing models and treatment and testing available. Having the interventions we've done has allowed us to care for our community better.
We've had a couple of questions regarding CentraCare and how you're working and collaborating with non-CentraCare providers in the community, looking for some examples and collaboration there with the community, and specifically in the area of best practices.
I'm going to mention a high level, and then George and Joy can chime in. When the pandemic hit, probably early February, as we set up our incident command, we recognized that there are a lot of healthcare folks that are not a part of CentraCare in a broad geography. CentraCare is in 18 counties. We help take care of 750, 800,000 Minnesotans. And so we started a regional collaborative. George helps lead that conversation, and they're meeting maybe weekly. George can fill in the details to talk about how we collaborate on everything from testing to transferring patients to supply chain management and all those types of things. Recognizing that if you are in a separate organization from CentraCare, you certainly have the right and the privilege and to do things the way that you want to. Specifically related to your question about guidelines, we, as well as others, are inputters into state and CDC recommendations, whether it's masking, social distancing, guidelines related to doing surgery and ambulatory procedures, and et cetera. So CentraCare follows the MDH, American College of Surgeons, and other expert bodies' advice, and we don't go off and do things on our own. So we're happy to collaborate with anybody that gives us a holler. And in several cases, we have developed robust networks. George or Joy, you want to answer more?
Joy, do you want to start?
You go ahead, George.
Okay, I'll add on to what Dr. Holman said. Daily basis, we are collaborating with our regional partners and a broad range of people, both public health and then the clinical providers, again, outside healthcare organizations. In fact, I think it's this evening we have another one, an example where we do the regional approach to managing patients and people. And how to shift the right people into the right location is a key part. We're also collaborating especially well with, we're working on that with the long-term care facilities. That's another case, as I think both Joy and Dr. Holman had mentioned, our most vulnerable people are in those facilities. So we have a group that's basically dedicated to making sure that that's a good relationship. And we sit on meetings at least on a weekly basis at a leadership level, and then daily there's work getting done on that behalf. We have shared and will continue to share what we've identified as our care protocols or guidelines. We have them on our CentraNet and shared those outside of CentraNet too, so that as we develop a protocol, you might say universal masking or patient visitors or remdesivir treatment, we both connect with national leaders and then implement it locally and share that, and help shape policy and procedures at the state level.
Just a couple other things that I would add is that we do have, a number of physicians and other providers that are on our boards, or we have relationships with, or are really helping for us to guide decision-making when it comes to turning on and increasing the number of surgeries that we are having within CentraCare. So we have a surgeon advisory board, and we have non-CentraCare providers on that board that guide in that decision-making. So there's a number of personal phone calls that happen. George is constantly on the phone answering questions and being a resource to non-CentraCare providers within our region. And then on a more global scale, what's been really helpful is we have a number of physicians that have trained other places where COVID has started. So an example is on the coast, and we continue to hear and collaborate and work with them on best practice guidelines or what they found helpful. Taking guidelines from the University of Washington as an example and using those as best practices. So to have that really not only national but international network of providers coming together to guide us in our response has been very helpful.
And I'd mention one other really neat area of collaboration, which owes thanks to many folks. We have a number of large employers in the meat production area. And by collaborating with public health, CentraCare, as well as the plants themselves, we have been able to do just remarkable testing. The other day, I think we did 1,100 tests in 8 hours with the help of law enforcement, a plant, and CentraCare folks. And this is what it takes to help manage the public health issues related to a pandemic in a targeted population. So many thanks to lots of folks. And there are other companies that have reached out to us as well to see how we can work together.
I think hopefully time for a few more here. To what extent is tracing being pursued in our community, and does CentraCare have a role in that?
George, let me grab that first and you and Joy finish up. So what is the purpose behind tracing? Until there is a known vaccine or a known immunity status for a great chunk of the state of Minnesota or for America, we have to live with the virus. And of course, living with the virus means managing the virus. And key to managing an infectious disease is understanding the source of the infection. And that's why managing the test, tracing the person who is positive or infectious, controlling the contacts that that person has, is key to minimizing the impact that the disease has on other people than the person who's infectious. And this is well based in science and virology and infectious disease science. And so that's why that is so important. That part of the equation requires extensive collaboration with all sorts of folks, with the employer, if an employee is positive or infectious, with public health officials, and with local healthcare providers. So it's complicated, but essential as we learn to live with the virus. George or Joy, add more.
I see tracing happening here routinely. We do it both for our own employees, with their possible exposures or travel or other ways that they get ill. And we work closely with public health and Minnesota Department of Health. I mean, the major part, as Dr. Holman was saying, of tracing is, I call it, it's a containment. When you get an outbreak or a case, if you can surround it and contain it, micro-containment or mass containment, it manages that spread. So we do that routinely. In fact, early on, we set up a case where before we had the testing that we had, we were identifying people clinically that were of a concern. So we set up a process where we could identify them and then use local Stearns County Public Health to do outreach and monitor and help manage that spread. Now that we do have more testing, we're identifying more people, and we are still working with them to do that. Tracing is a key part, I think, of that return to, road to recovery.
As businesses and organizations look toward offering services to the public, what is the most important thing employers should focus on, in your opinion?
I kind of covered that in living with the virus, and that is traditionally American commerce has had a social closeness to it. There was a part of the fabric, whether it was a restaurant, sitting at a bar, a church, a movie theater, going to hardware store, going to the grocery store. And so this notion of social closeness is antithetical to social distancing. And so if we're going to try to manage the virus, and as we modify social distancing to become more close, what are efforts that we can undertake that will minimize this infectious element of the virus until we have a vaccine? That, unfortunately, is a moving science. As we learn more and more about the characteristics of the virus, we'll be able to be more precise. But for now, and I want George and Joy to weigh on this because they spend a lot of time on this, it's about wearing a mask in public, keeping 5-6 feet away from someone, covering your face, all those things that George mentioned in his slide and Joy talked about, wearing gloves. Do we reposition tables in a restaurant different? How do we manage this? And it would be nice to have a set of definitive guidelines, but I'm afraid we're all learning at the same time, and we'll continue to have to modify. But Joy and George, please weigh in.
So I think in addition to what Dr. Holman said, you know, the governor's response last night also indicated that some guidance would be coming out from their office. So following that, making sure that employees have the ability to speak up when they feel unsafe. But I would also say that, you know, think about who from your environment you actually need to bring back to your place of business. And perhaps not everybody is needed. Maybe it's a portion of your team that you need to bring back. And if others can continue to work at home to continue to do that.
Okay, so one final question here, I think, if you can spare a few more minutes with us. Somebody's asking the recent children's disease that is similar or it's mimicking the Kawasaki disease. Is this actually COVID and or what is it, and what would you suggest for parents?
George, take a whack at that.
Thank you. I do believe it's actually similar to Kawasaki's. Kawasaki's, you'd call it a post-infectious or a inflammatory condition that affects many of the vessels and other structures in our body. I do believe this is similar. I think it is also a challenge. The research is still being done and being developed, and I know that couple of our lead pediatricians, Dr. Kulis, Dr. Cruz, Dr. Amsbury, I'll say they're on top of this. They are connecting with New York. They are identifying what we should be doing. The manifestations of COVID are expanding. We covered some of the major symptoms before. There are another group that affect blood vessels, potentially manifesting in the skin. There's an inflammatory cascade to this. There's an interleukin storm or a cytokine storm. There's kidney damage. There's cardiac injury. Obviously the damage to the lungs and the long term. So what I would say, and so that kind of shows the Kawasaki's is part of that we've seen in other viruses and infections in the past. What we want to be aware with COVID is more reasons perhaps to say, well, if I just get mild symptoms, I'll be okay. Let me go get the virus. I think that's a big risk because we don't know exactly what the long-term effects are. If we can minimize how many people get this and over what timeline, that gives us a more ability to research and identify and get new strategies to keep people safe. It's perhaps, if I reflex to one more, is I know the comparison has been made, let me just do an old chickenpox party. Let me just go get everybody exposed and get this over with. That's a big risk. If we do it uncontrolled, we will have more people, including kids like this, get exposed too early, too much, and they'll suffer serious consequences.
I would, this is, Ken, as we wrap up, I had 2 further points to mention. And so this perhaps comes more from me as a leader rather than specifically CentraCare. What are the 2 points I'd like to finish off with? One is that we are trying to manage a complex polarity that is apolitical. And the polarity is this simply. On the one hand, we shut the entire country down for months to manage a disease, which causes untold damage to human lives and businesses in the American way of life. That's on one end of the spectrum. On the other end of the spectrum is open everything up, carefree, and go back to the way that it was. And that has a second set of consequences. We are trying to manage a conversation in the middle. And that middle conversation is best done by thoughtful leadership. And I'd like to think that the best way to approach it is by being apolitical, because both sides of the fence have complex consequences. And I'd finish by saying thank you to all of you for being a leader. This community is remarkable. And one thing that we constantly emphasize is the attributes of leaders in times of crises. And there are many books written about this, but the ones that we use are trust, compassion, stability, and hope. And so thank you on behalf of our organization, and thank you on behalf of our citizens. Together we'll get through this. So thank you.
Great. Thank you, Dr. Holman. And Dr. Plowman and Dr. Morris, this was wonderful. Many of you may have noticed we are recording this, so we will put this up for a short time on our website for people who weren't able to view it today. I'm guessing about a week, because then we're going to have pretty outdated information in some of those slides. And I know Dr. Holman and CentraCare have been resources to the Chamber for information and these kinds of presentations since the beginning. So when it makes sense, perhaps we can welcome you all again for a short presentation to update people. Thank you so much for your time today. And thanks to everyone who came on. I really appreciate it. And the Chamber is here to help and support you as you go through reopening. So please call if we can be of assistance to you in any way. Thank you for your participation today.
Thank you.